The reason chronic back pain keeps coming back has nothing to do with muscle weakness, and everything to do with how your patient's brain has stopped seeing their spine. Neuroimaging research shows that in chronic low back pain, the cortical map of the lumbar multifidus and transversus abdominis becomes literally smudged, overlapping, imprecise, and displaced. Most clinicians believe the problem is inhibition or weakness. That belief is exactly why targeted strengthening alone keeps failing. When you keep loading a nervous system that has lost its cortical precision, you reinforce the same maladaptive pattern. The muscle activates later, the map stays blurred, and the pain cycle continues, not because your patient isn't trying, but because the brain hasn't been retrained to know where the spine is. In this video, I'll show you the 3 clinical targets that drive positive neuroplasticity, starting with the one assessment finding that tells you immediately whether you're dealing with an under-control or an over-control presentation. I'm really excited to share this with you. I built this video from my own content using Notebook LM, and there's something valuable in it for you at every step. Please enjoy it all the way to the end.
For decades, musculoskeletal medicine has approached chronic low back pain through a single dominant lens: structural wear and tear. The standard clinical prescription derived from this model is ubiquitous. If the spine is hurting, the patient is told to strengthen their core and consciously brace their trunk against mechanical loads. This biomechanical approach drives standard physical therapy protocols, Pilates instruction, and general medical advice. However, this model struggles to explain a common clinical observation. Many patients who present with severe chronic pain already exhibit high levels of superficial trunk stiffness and visible muscle tension. While heavy abdominal bracing might reduce movement pain in the acute phase of an injury, it often evolves into a rigid protective strategy that limits functional mobility. Maintaining a permanent anatomical girdle reduces the body's movement options, which increases long-term tissue stress and accelerates fatigue. The impairment of the deep stabilizing musculature in these patients is rarely an absolute deficit in force production. They have the raw strength. The issue lies elsewhere. If muscle strength and artificial stiffness were the primary solutions for chronic low back pain, standard interventions would have a much higher success rate than the clinical data currently shows. In basic human biology, acute peripheral tissue damage typically heals within a 3-month window. This chart shows an injury's timeline. The first curve demonstrates mechanical tissue healing, which spikes early and resolves to baseline by 3 months. The second line represents nervous system pain signaling. Even after physical tissue repairs itself, pain signals can remain elevated indefinitely. This divergence suggests that past the 3-month mark, the pathology resides within the processing of the nervous system, rather than the original structural damage. The clinical deficit involves a breakdown in motor control, an umbrella term covering the timing of muscle activation, protective adaptations, and neuroplastic changes. To understand why the pain persists, we have to look past the muscle fibers and analyze the specific timing of the neurological signals that govern them. Treating chronic low back pain as a purely mechanical problem ignores the biological realities of modern neuroscience. The investigation begins with the spine's EAP stabilizers, the transversus abdominis and the lumbar multifidus. In a healthy state, these muscles provide anticipatory trunk control, operating on an automatic feed-forward loop. This electromyography readout shows the feed-forward loop. The central nervous system activates deep muscles milliseconds before limb movement, preparing the spine. But in chronic pain, the sequence changes. The activation is delayed, occurring only after the limb starts moving. Because of this delay, the spinal segment is forced to absorb the initial mechanical load without the necessary protection. This proves the issue isn't weakness. The muscle is physically capable of firing, but it has lost its contextual precision and timing. Since the deep stabilizers are late to the task, the central nervous system must manufacture an alternative strategy to protect the spine. The nervous system compensates for this timing gap by shifting the motor load to the superficial layers of the trunk. The brain recruits the large, global muscles to lock down and guard the area, creating a state of constant over-control. This guarding strategy limits the patient's movement options to a single, rigid pattern, sacrificing the variability the spine needs for healthy function. While this bracing might protect the spine during an acute injury, maintaining this tension for months triggers changes in the muscle tissue itself. When this rigid loading pattern persists, the physical composition of the lumbar multifidus begins to transform. Microscopic views of the tissue show dense, deep red muscle fibers shifting toward a paler color, interspersed with encroaching pockets of fat. This represents a shift from endurance-heavy, fatigue-resistant type 1 fibers to highly fatigable type 2 fibers. This fiber transition leads to the fatty infiltration and structural atrophy frequently seen on clinical MRI scans. This atrophy appears as a downstream result of the altered neural strategy, rather than the initial injury that triggered the pain. This decay leaves the patient with very little muscular endurance, which reinforces the brain's reliance on rigid bracing and maintains a cycle of load intolerance. To find the root of this cycle, we have to look up the neural pathways and into the brain. Motor output is orchestrated by the primary motor cortex, which maintains a map of every muscle in the body. Data from fMRI and transcranial magnetic stimulation allows us to visualize this map. In a healthy brain, the centers of gravity for the TRA and the multifidus are distinct and sharply defined. These separate neural maps allow the nervous system to achieve precise, dissociated control over individual muscle groups. But when chronic pain signals flood the brain, the cortex reorganizes. The focal points for these muscles expand and blur together into a single overlapping zone. This neuroplastic change is known as cortical smudging, the loss of discrete motor representation in the cortex. This blurred mapping means the brain can no longer isolate or sequence these stabilizers during movement. This confusion in the motor cortex is linked to central sensitization, where the nervous system amplifies its threat response, treating non-harmful stimuli as pain. Traditional core bracing becomes ineffective in this state, as the brain's internal map of the muscles is too disorganized to execute the command precisely. Chronic spinal pain is driven by a combination of delayed timing, movement rigidity, and smudged cortical mapping. Recovery requires a shift in how these patients are managed. Standard strengthening and rigid loading patterns fail to address the timing error and may actually increase the brain's sense of threat. Specialists are now turning to cognition-targeted motor learning as the primary intervention. These protocols use low-threat, high-precision tasks to bypass the brain's guarding mechanisms and re-establish proper coordination. These graduated exposures aim to reverse neuroplastic changes, providing the specific sensory feedback required to redraw and refine the cortical map. Resolving persistent spinal pain requires moving past the attempt to build a thicker anatomical pillar and focusing on the restoration of a precise, confident nervous system.